Hello everyone. So today we are going to discuss about rest of the hypoxia and some other applied aspects of respiratory physiology. In last lecture we have discussed about types of hypoxia and different characteristics of different types of hypoxia. Now today we are going to discuss about symptoms of hypoxia. Based on symptoms we can say the hypoxia it is mainly divided into three types: fulminant, acute and chronic. Now let's start with first fulminant hypoxia. Now the meaning of fulminant, it is very severe and very sudden. So as the name itself suggests, fulminant hypoxia, it is severe hypoxia developing very fast, and it happens when there is sudden exposure to an arterial oxygen tension less than 20 millimeter of mercury. For example, aircraft accident that happens at very high altitude. Over here, person he becomes unconscious within 15 to 20 seconds, and if no oxygen is provided, then brain death it will occur in 4 to 5 minutes. Next is acute hypoxia. The meaning of acute is of short duration. So this acute hypoxia it develops when there is exposure to arterial oxygen tension of between 25 to 40 millimeter of mercury. It usually happens at very high altitude. Now the symptoms over here are lack of coordination, then slow reflexes and slurring of speech, and person may become unconscious, and even coma and death may occur. Next is chronic hypoxia. Meaning of word chronic is of long duration. So this happens when there is exposure to low PO2, that is arterial tension between 40 to 60 millimeter of mercury for long periods. And over here the symptoms, they may be severe fatigue, dyspnea, shortness of breath and respiratory arrhythmia. For example, there is giant strokes breathing that we will discuss in later part. Now next is signs of hypoxia. First sign is cyanosis. So it is bluish discoloration of the skin and mucous membrane. It is caused by presence of more than 5 gram of deoxyhemoglobin per 100 ml of blood. Now it is of two types: peripheral cyanosis and central cyanosis. Peripheral cyanosis, it is seen in nail beds and is suggestive of stagnant hypoxia. Central cyanosis, it is usually seen in earlobes, mucous membrane of lips and tongues, and it is usually suggestive of hypoxic hypoxia. Now cyanosis, it is not a reliable sign of hypoxia because anemic hypoxia and histotoxic hypoxia, it never develops cyanosis. Next sign is tachycardia. Tachycardia means increase in heart rate above 100 per minute. It is seen due to peripheral chemoreflex response to the low arterial oxygen tension. Next sign is tachypnea. Tachypnea means rapid breathing and deep breathing. Deep breathing, it is also known as hyperapnea. Now it is also reflex response to hypoxia that are activated by arterial chemoreceptors or peripheral chemoreceptors. Now we are not going into much details of sign and symptoms of hypoxia, because if you have understood regulation of respiration and types of hypoxia, then you will be easily able to understand sign and symptoms of hypoxia. Now let's move towards treatment part. Now the best treatment of hypoxia, it is oxygen therapy, either with normal atmospheric pressure or with high atmospheric pressure. High atmospheric pressure therapy, it is known as hyperbaric oxygen therapy. Now oxygen therapy, it is 100% effective in hypoxic hypoxia, around 70% effective in anemic hypoxia, around 15% effective in stagnant hypoxia, and it is not much useful in histotoxic hypoxia because over here whatever amount of oxygen we provide, cell cannot utilize oxygen. Now if we talk about indication of hyperbaric oxygen therapy, then it is required in carbon monoxide poisoning, because carbon monoxide, it is having very high affinity to hemoglobin as compared to oxygen. So if we provide hyperbaric oxygen therapy, oxygen will be able to replace carbon monoxide. Next is anemic hypoxia. Now anemic hypoxia, it will be able to provide in this condition. If we provide hyperbaric oxygen therapy, then more amount of oxygen will be dissolved and more amount of oxygen will be delivered to tissues. Next is, it is utilized in decompression sickness. About this decompression sickness we will discuss in detail in next lecture. Now it is also given in wounds with poor blood supply. Now there are certain requirements or we have to about which we have to take care when we are using hyperbaric oxygen therapy. The hyperbaric oxygen, it should not be used with pressure 2 to 3 times of that of atmospheric pressure and should not be used more than 5 hours because of high chances of developing oxygen toxicity. Now let's discuss about oxygen toxicity. So if 100% oxygen is given more than 8 hours, there is development of irritation in respiratory tract, and which is first clinical feature of oxygen toxicity. It is seen due to oxygen free radicals like superoxide, hydrogen and hydrogen peroxide, and this produces congestion, sore throat, substernal discomfort, sneezing, coughing and tachypnea with bronchoconstriction. Now if 100% oxygen is given for more than 24 hours, then there is development of bronchopneumonia. It is due to decreased surfactant and decreased macrophage activity. Now these symptoms, they are seen in adults. Now in infant, hyperbaric oxygen therapy, it can cause lung cyst and densities and retinopathy of prematurity. Now hyperbaric oxygen therapy can also cause cerebral symptoms like muscle twitching, ringing in the ears, dizziness, convulsions and coma. Now convulsions without warning are most severe sign. So these are the symptoms of hyperbaric oxygen therapy. With this we finish our topic of hypoxia. Now we are going to discuss about certain more applied aspects of respiratory systems. Now these topics are going to be very short. They can be asked into the examination in very short questions. Let's start with first, that is dyspnea or air hunger. Dyspnea simply means difficulty in breathing. Now if we talk about causes of dyspnea, its physiological causes, it is seen in severe exercise or in case of increased ventilation. And if we talk about pathological causes of dyspnea, it is seen in stagnant hypoxia, bronchial asthma, even in severe anemia and in heart failure. Next is apnea. Apnea means stoppage of respiration. If we talk about its physiological causes, then voluntary apnea during deglutition, even after hyperventilation, or in case of children when they are doing breath holdings when they are angry, or during sleep. So all these are physiological causes. Now if you talk about pathological cause of apnea, then it is seen in respiratory failure. Next is sleep apnea syndrome. It is of two types, obstructive and non-obstructive. First is obstructive sleep apnea syndrome. Now over here, inspiration is prevented by the transient blockage of the airway by decreased tone of pharyngeal muscle during sleep. Over here, partial airway obstruction, it leads to snoring. It is usually seen when person sleeps after long, tiresome or hard work. Now sleep apnea associated with extreme obesity, it is known as Pickwickian syndrome. Next is non-obstructive sleep apnea syndrome. It is also known as central sleep apnea syndrome. Over here, there is complete stoppage of rhythmic activity from respiratory centers. It usually results from decreased chemoreceptor sensitivity to oxygen and carbon dioxide. It is one of the possible cause of sudden infant death syndrome. Next, we are going to discuss about hypercapnia. It means excess carbon dioxide in body. Now, its common cause is hypoventilation or circulatory deficiency. Now, if we talk about its clinical feature, then hypercapnia, it is divided into different types according to its level. When partial pressure of carbon dioxide is 40 to 80 mm of mercury, then the symptoms, they are hyperventilation, dyspnea and signs of central excitation. Over here there may be headache. It is due to increased cerebral blood flow and increased intracranial pressure. When partial pressure of carbon dioxide, it remains around between 80 to 120 millimeter of mercury. It shows clinical features of central depression, drowsiness, unconsciousness, stupor and coma. And when partial pressure of carbon dioxide, it becomes more than 120 millimeter of mercury, it leads to death. If we talk about treatment, then we have to treat over here underlying cause which leads to accumulation of carbon dioxide. Now oxygen therapy, it often worsens the condition because over here carbon dioxide keep on accumulating. So first we have to remove that. Now next is asphyxia. Now if you want to define, then it is characterized by combination of hypoxia and hypercapnia. It can be acute or chronic, and if it is acute and not treated, it leads to death within 5 minutes. If we talk about its causes, then acute asphyxia, it is seen in strangulation, acute tracheal obstruction and paralysis of diaphragm. If we talk about chronic asphyxia, then lung disease causing right ventricular failure. Now this asphyxia, it is too vast of a topic. About its detail you will learn into second year of MBBS in forensic medicine. Next is periodic breathing. It is abnormal respiratory rhythm. There is repeated sequence of apnea followed by hyperventilation. If we talk about types of periodic breathing, then it is Cheyne-Stokes breathing, Biot's breathing and Kussmaul's breathing. First is Cheyne-Stokes breathing. So it is type of periodic breathing that have alternate cycle of hyperventilation and hypoventilation. Now there is slow waxing and waning of breathing every 40 to 60 seconds. What it means is person suddenly breathes very deeply and fast, then after some time the breathing will become slow and shallow. Again after some time it will become fast and deep. These cycles keep on repeating. If we talk about its physiological base, then the basic cause is first hyperventilation due to any cause that will lead to decreased partial pressure of carbon dioxide, which will inhibit the respiratory center, and that will cause apnea. And once apnea happens, it will lead to accumulation of CO2, which will again stimulate the respiratory centers, which will again wash out carbon dioxide. Again it will lead to apnea. So these cycles keep on repeating. In this figure you can see graphical recording of Cheyne-Stokes breathing. Over here first you can see there is increase in respiration followed by decrease in respiration. Again there is increase in respiration followed by decrease in respiration. If we talk about causes of Cheyne-Stokes breathing, then it is seen in left heart failure. It is also seen in brain damage. In physiological condition, it will be seen during very deep sleep. Even it is seen at high altitude and in newborns. It is also seen in voluntary hyperventilation. Next is Biot's breathing. It is also characterized by alternate periods of hyperapnea and apnea. But the difference between Cheyne-Stokes breathing and Biot's breathing is that over here there is no waxing and waning of breathing, and it does not occur in physiological conditions. It occurs only in disease condition that involves brain injuries or meningitis and some other conditions. Next is Kussmaul's breathing. It is usually seen in diabetic ketoacidosis. Accumulation of metabolic acids. It stimulates respiratory center, which leads to rapid and deep breathing known as air hunger. Now let's talk about certain terminology of respiration. First is eupnea, which means normal respiration. Next is bradypnea, which means decrease in rate of respiration. Next is tachypnea, it means increase in rate of respiration. Next is hyperapnea. It increases in rate or and force of respiration without discomfort. Next is apnea. it is temporary stoppage of respiration. Next is hyperventilation. It is increase in rate and force of respiration. Next is hypoventilation. It is decrease in rate and force of respiration. Next is dyspnea. It is difficulty in breathing. Next is periodic breathing, which means abnormal rhythm of breathing. Next is hypercapnia. It is increased carbon dioxide content of blood, and when there is decreased carbon dioxide content of blood, it is known as hypocapnia. Next is pneumothorax. It is collection of air in pleural cavity. Next is pneumonia. It means inflammation of lung tissue in which alveoli are filled with fluid and inflammatory cells. Next is bronchial asthma. Over here there is constriction of bronchioles. It leads to obstruction of air passage due to allergic reaction. Next is pleural effusion. It means collection of fluid in pleural cavity. Now, in today's lecture, we have not gone into too much detail of all of these different applied aspects, but you will learn about all these in details when you goes into ward posting in second year as well as third year. So with this, we finish our today's lecture. Thank you. And today there will be no summary at the end.